I'm really pleased to talk today about some topics related to WM and how it affects patients. So for those who don't know, we are in Birmingham, which is in this part of the UK. Obviously everyone here knows, but and you can see we're kind of just across the way from Amsterdam. We're actually at the same sort of level. So it's really good to hold hands with our colleagues in Europe. And thank you also to the IWMF, who are making great strides in having international collaborations. Fantastic. So I'm going to talk about a few nuggets related to WM, which come up time and again, and some are rarer than others. So I'm going to cover peripheral neuropathies, a condition called AL amyloidosis, which has been alluded to before, and also when WM goes to the central nervous system, causing something called Bing-Neal syndrome. And I'll talk about symptoms, the diagnostic tests that are needed, and also the possible treatments that are given. So starting with peripheral neuropathy, I think the best place to start is with a tour of the nervous system. And you can see here that this is a picture of a typical nerve, which of course has the London eye attached to it, but that's just for effect. You've got the nucleus, which is the London eye, and then the nerve fiber, which goes down to the organ where it's either supplying a muscle or it's receiving signals from sensory nerves. And you can see that actually nerves are not just wires, they're very complex electrical conduction systems, and they have a special insulation sheath called the myelin sheath. And any of these elements can be disrupted by disease and inflammation, and that can then cause the nerves not to function so well. So we split the nervous system up into the central nervous system, which comprises the brain and the spinal cord. That is shown by the arrows there. The brain, of course, is the center of everything and conducts everything that we do, a lot of it completely unconsciously. And then the peripheral nervous system conducts all these instructions and provides information back to the brain using by the nerves themselves. This all happens extremely quickly, and breathtaking speed. You can't even conceive how fast this happens. So you can understand that when something disrupts this conduction, how there can be malfunctioning of the way the nerves work. And the way these nerves work is that they need a really good blood supply. They need, like any cells, they metabolize, they produce, they need nutrition, they produce waste products. That all has to be cleared out. And so you can imagine a very long nerve which starts in the spine at the bottom there, the sciatic nerve. It's about 1 meter long in many people, going right down to the bottom of the foot. You can see how if there's a problem there, especially the end bit can get quite affected, and that's when you can develop what are called length-dependent neuropathies, which I'll talk a bit more. So I mentioned the myelin. So this is a cross-section of a nerve, and you can see that there are special cells which form myelin, called Schwann cells, and they form like an onion ring surrounding of the nerve itself. And as you go, you start off with a big nerve, which has nerve supply, blood supply, the veins and the arteries. You then have bundles of nerve fibers, and so as you go down and down, to higher magnification, you end up with a single nerve cell, a wire surrounded by the myelin sheath. And this electrical conduction is also contributed to by some chemical transmission between nerve cells. And it is some of these chemical transmissions that we interfere with when using medication to counteract symptoms of nerve, such as pain, for example. So it is all about electricity, and in fact the conduction of electricity is not just along the wire, but these myelin sheaths, you get this jumping of the nerve impulses. So the best way to look at nerve damage is if something happens to the insulation, myelin sheath, then it's called demyelinating neuropathy. And that has certain features both in terms of symptoms, but also in terms of the results of nerve conduction tests that many of you may have had along the way. On the other hand, when the wire is damaged, the axon, you can see that actually the disruption of electricity happens for a slightly different reason. And the kind of symptoms people get with wire damage as opposed to sheath damage is variable. And that is where neurologists help us to understand which is the predominant factor and try and work out the cause of the problem. There's another bit of the nervous system called the autonomic nervous system. And I think another good name for this is the automatic nervous system. And this is, you may well have heard of this system, there's the so-called sympathetic nervous system, which is the bit of our nervous system that we developed to sort of run away from T-Rexes and that sort of thing, the fight or flight mechanism. So you release all sorts of hormones like adrenaline, cortisol, and the nerves literally get you to spring into action, and your pulse rate goes up, and your blood vessel flow increases. And then there's the rest and digest part of the nervous system called the parasympathetic nervous system, and that helps to basically, that's when we recover and rest and relax and improve and heal up, etc. Now, we talked a bit about fatigue earlier, and I think probably one of the reasons a lot of people have fatigue is that the fight and flight part of the nervous system is kind of constantly on because of stress and other things, as well as whatever chemicals that the WM cells in patients might produce. And it's probably one of the mechanisms why there is a lot of fatigue, but a lot more work needs to be done in this area. So this is a kind of detailed picture of what actually happens with the function of the autonomic nervous system. But to kind of break it down to what it means for symptoms, if the autonomic nervous system is not working well, and this can happen through a number of mechanisms related to the WM or the IgM, people can get a reduced appetite, they may feel full easily, you may lose weight because the gut isn't working as sort of seamlessly as it should. You may get uncoordinated digestive systems, diarrhea or constipation, and other things such as the regulation of blood pressure and pulse may be affected, so people may stand up and suddenly feel very lightheaded. And of course, if you're on blood pressure medication, that can be made much worse. You may have blackouts, unexplained loss of consciousness. You may get an erratic heartbeat, palpitations, and you may also get swelling of the legs because of the dysregulation of the way the blood vessels hang on to the blood supply, basically. So relatively vague symptoms, but if they are present, then it's worth noting that this bit of the nervous system exists. So what can you do as someone with WM if you think you have a neuropathy, or if you do indeed have a neuropathy? It's really worth knowing or noting when your symptoms started. Have they come on gradually, or have they come on very quickly? So days to weeks or months to years? How quickly are things changing? What triggers the problems? Is there anything, was it related to any treatment that you had? Because some treatments for cancer are quite toxic and they can inflame nerves. How is it affecting you? Is it mainly sensation? Is it strength? Is it balance? Are you getting tremor? Are you having pain? Is it a combination of these two? Or is some things more predominant than others? Are both sides equally affected? Is it mainly in the legs, the hands? What makes the symptoms worse? Is it position or movement, or is it improved by movement? Does it get worse by cold temperatures? And what helps? Is it better when you move around or walk or stretch or whatever? Are there some medications that can help you? And how does it impact on your function? So if you have neurological symptoms, it's worth thinking of this like a little checklist to see what is going on. Because when you see your doctor, you can give them this information, even if they don't ask for it. Because I have to be honest, I see a lot of patients with nerve damage, but many doctors don't necessarily do that. And time is short for everybody. So if you are armed with those symptoms, it can make conveying your picture easier to the doctor that you see. So if you do have neuropathy symptoms, the question is it due to the WM or the IgM? Because that is key to giving you the right treatment. In order to help, a number of tests can be undertaken and should be undertaken. I wouldn't say all of these tests are necessary for everyone, but one of the things that can be done are called conduction studies, where electrodes are attached to nerves at different ends of the body, and then electrical conduction is measured using probes and a machine. Similarly, you can put needles into muscles and see how they react, so that's called an EMG. So this is something that is done frequently to sort of understand what the nerve problem is. I have to say, in general, it's quite hard to get these done because there's often a long waiting list for this, but I think this is something we do rely on a lot to deconstruct what is happening with nerve problems. It's important to realize, though, that sometimes you may have neuropathy symptoms, which are very real, but when you have nerve conduction tests, they're actually normal. And that's because nerve conduction tests look at large fibers, whereas you have very small fibers in your body, which mainly mediate pain, and they're not picked up on nerve conduction tests. So it can be a bit of a tricky area to navigate. The other thing about nerve conduction studies is a single study can give you a snapshot, but if you want to see what's happening over time, you may need more than one study after several months. But that'll be guided by your neurologist. Then a nerve biopsy is done rarely if we're really still trying to work out the cause of the damage. Sometimes WM cells can enter the nerve and cause problems. Other times the antibodies can go and disrupt the nerves. So the biopsy helps us to understand that. So the IgM can have activity because it's an antibody. It can actually misregister some of the proteins on our own nerves in error and think of them as foreign, as some kind of risk. And a frequent target are some of the proteins on the nerve, usually the nerve sheath, something called anti-MAG antibody. And there are a whole range of other antibodies, but the MAG one is the most common. Sometimes the IgM can cause a neuropathy without an actual known antibody, because we don't know all the antibodies that cause problems. We know many of them, but there are many others that we don't know yet. So often there are similar symptoms, but the disorders may be a little bit distinctive, and that's where all the testing and examination comes in. Some people can have anti-MAG antibodies and be completely asymptomatic. Others can have quite progressive symptoms, and others may very gradually get worse. So it's not something that immediately means you need treatment. And sometimes you may have an anti-MAG and it may not be relevant at all, and your neuropathy may be caused by something else. So it's important to make the connection, because if you have treatment for anti-MAG but it wasn't the anti-MAG, then you've had treatment for no reason. So there are anti-MAG tests, which is a blood test, and these, just a word of warning, there are many kinds of tests that are done. And the best way to look upon it is if you have very high levels of anti-MAG antibodies, and a cutoff often uses 70,000, then it's more likely that they could be related to a condition. Very low levels are just there and probably are not doing anything. So there are varying degrees of anti-MAG positivity. And you can see here that how the pictorial illustration of how the MAG antibody disrupts the myelin sheath. So if someone does have anti-MAG neuropathy, who gets treated? Well, not everyone. It depends on, it's a balance between the damage being caused, the rate of change, and the risk from the treatment. So people who have progressive disability should be considered for treatment. And obviously people who have less nerve damage established are likely to recover to a greater extent. But many people have treatment, and the best perhaps can be hoped for is that they stabilize. But time is important to measure the effect of treatments. Many treatments have been tried, and there are other inflammatory neuropathies for which something called intravenous immunoglobulin is often used and can be beneficial. But it really has no place in anti-MAG neuropathy, so it's important to get the diagnosis right. Steroids can be used, prednisolone, etc., but beyond short-term containment of the situation, it's not something people should stay on forever. Rituximab can be effective, but its use should be done under specialist guidance. And depending on the context, you may need to add chemotherapy agents if there's a lot of WM in the system, because there are more cells to contain. And BTK inhibitors like ibrutinib and zanubrutinib can also work. And so this is pretty much what I said earlier. If there is this sort of more of a WM setting than an MGUS setting, coming back to my previous colleagues' talks, then you may need to give more in the way of combined treatments. So AL amyloid is another entity in which the IgM protein and the so-called light chains have this unfortunate property of becoming quite sticky. And the stickiness of the protein, which is not something that just happens, we don't know why, those proteins can deposit in tissues and cause damage because they literally sit there and make a nuisance of themselves and inflame tissues. And amyloid can affect various tissues, including the heart, the nerves, the kidneys, the gut. And so it's a lot of the autonomic things I mentioned earlier. Those are the kind of symptoms that arise. It can also cause bleeding and bruising problems. It's a very rare complication, but if it's present, it's very treatable and should be treated promptly. So it is an important diagnosis to make. And it's one of these diagnoses that if you don't think about it, you won't seek it out and get it confirmed. And the best way to diagnose it is to get tissue, whichever organ is malfunctioning, to do a biopsy and prove that it is present. And the way to treat it is, first of all, to have a supportive treatment to help the organs function better, and then to give actual treatment against the underlying WM. And again, complicated area, but it's similar treatments that we use. Finally, and I've got very few minutes, I'm sort of overrunning, Bing-Neal syndrome is a disease when WM cells actually invade the central nervous system. And depending on which part of the nervous system they invade, you can get problems with thinking or functioning, balance, headaches, a variety of things can kind of creep up. And it can happen when WM is in remission or when it's actually actively needing treatment. And we mentioned a bit about the CNS, so I won't go over that again. And when we treat Bing-Neal syndrome, it's important to give treatments that will cross this very special barrier that protects the brain in health. And so basically we would give treatments that, I'm skipping this just for time. It is a rare complication. It's probably underreported, but we increasingly see it. So if you have symptoms such as headaches, difficulty hearing, balance problems, unexplained symptoms that are persistent, personality change, even loss of memory, these need to be reported. And the best way to examine this is to do scans and to examine also the CSF, so that we look for evidence of WM cells in the fluid, as well as checking the disease as a whole. And the treatment consists of a variety of options which would be decided upon or recommended by your team, and include chemotherapies as well as BTK inhibitors. So sorry to have rushed through that, but to conclude, just to say that both IgM and WM cells can affect the patient in many ways. There are many effective therapies, but it's really important to get the detail right, and you can help by having a clear understanding of your symptoms. Thank you.